I didn't have any risk factors that I knew of at the time. I did have risk factors, but none that I knew of. I'd been a distance runner for 19 years. And so I was really into this. How could this have happened to me, of all people? Not one person before I left that hospital asked me, have you ever had any pregnancy complications? And it turns out having a pregnancy complication like some of the ones I've just mentioned can increase your risk of future heart disease 3 to 4 times. Now that's more than high cholesterol or diabetes as a risk factor.
Hello and welcome to Friendly Pharmacy 5. My name is Lindsay Dixon, and today we will be speaking on the topic of women's heart health. Carolyn Thomas is a women's heart health advocate. She is also the survivor of a heart attack. She is an educator. She actually has a lot going on. And it's the second time we've had Carolyn on the channel. So Carolyn, thank you so much for coming back to the channel to talk a little bit more about women's heart health today.
You're welcome. Thank you for inviting me.
Carolyn, like I said, you do so many things, and you did have a heart attack some time ago that was misdiagnosed for about 2 weeks. And that's led you on a bit of an advocacy journey. It's actually led you on quite a bit of an advocacy journey. But I'd like to know from your standpoint, why is it that you do this? Because you could have just had your heart attack and just taken care of yourself and focused on yourself. And I think that would have been enough, and your family, right?
Yeah, for sure.
But you really got into advocacy. Why is it that what led you to pursue that so passionately?
Usually when I ask that, I say that you would not be talking to me today had I not been misdiagnosed in the middle of a heart attack. And that was the difference for me. I think if I'd had my symptoms, which were textbook symptoms, central chest pain, nausea, sweating, and pain down my left arm. So pretty classic symptoms. If I'd just gone into the emerge and they admitted me and treated me and sent me home, I would be that kind of a person. You just go on with your life, and my family would say, "Ooh, glad that's over." But because I was misdiagnosed, it took me about 2 days once I was discharged from the hospital to get really angry and start thinking, how could this have happened to me? How could that emergency physician have sent me home? And his exact words to me were, "You are in the right demographic for acid reflux. Go see your family doctor. You'll get a prescription for an antacid drug. And goodbye and have a nice life." So I couldn't get out of there fast enough. I was so embarrassed that I just made a big fuss over nothing. And when I got home, and then I started Googling, like, what the heck has just happened to me? Because I didn't have any risk factors that I knew of at the time. I did have risk factors, but none that I knew of. I'd been a distance runner for 19 years. And so I was really into this. How could this have happened to me, of all people? And that's what my friends and family were asking me too. You, of all people. I didn't have cholesterol problems. I was very active. I was healthy. I didn't see myself as the kind of person who would ever have a heart attack. I always say that heart disease did not matter to me until it happened to me. And then once it happened to me, I was like totally immersed in this subject that I'd never spent a second thinking about my whole life.
Mm-hmm. And I did not know that you were a distance runner and that you didn't have those risk factors.
No,
Neither did you, obviously.
no, I didn't.
So how many women, I know you do a lot of research on this, how many women might be walking around with heart disease right now with risk factors that they're unaware of? Do you have any estimates on the numbers or how big of a problem this is?
Well, I know I know that it's a big problem. They say that about 70% of women have at least one cardiac risk factor that they are not aware of. So you might have a high cholesterol number, but you haven't had your cholesterol checked, so you don't know that. Or you do have it checked, but you decide it's not a big problem, so you're not taking the medication that your doctor prescribes. But we do know that in Canada, I don't know the British Columbia state stats, but here in Canada, about 24,000 women die from heart disease every year. And that's significant because that is 5 times more women who die from breast cancer. And yet, I think if we asked the average woman, what are you most afraid of in terms of, horrible medical diagnoses, most women would say breast cancer, which is a terrible, awful, devastating diagnosis. But when you look at in terms of mortality and how dangerous it is, it turns out that heart disease is far more deadly to the average woman than breast cancer.
And so one of these risk factors that you mentioned that you weren't aware of is that there are certain things that can happen during pregnancy.
Yes.
Leave a woman more at risk for a cardiac event later on. And if you want to hear Carolyn's whole story about how she was misdiagnosed and later treated and later found out she had these risk factors, you can go back to our first interview and I'll link it in the description of this video. But Carolyn, can you go over a few of those risk factors? Because that was one of the things that was in the comments just so frequently.
Mm-hmm.
I had no idea.
Yeah. Yes.
Right?
Yeah. And I was like that too. I had no idea. As far as I was concerned, I was a healthy woman in my 50s who had no risk factors. But I learned 2 years after my heart attack from Dr. Graham Smith, who is an OBGYN. He's not a cardiologist. He's an OBGYN in Queen's University in Kingston, who has opened up a maternal health clinic for his high risk maternity patients. And the reason they're high risk is that they have had a serious pregnancy complication, which he knew from his research was linked to future heart attacks. Now, I knew nothing about that. These pregnancy complications include one that I had, which is preeclampsia, when I was pregnant with my first baby. And doctors always say the cure for preeclampsia is delivering the baby. Once you deliver the baby, then all of your symptoms go away. But that's not true. It's a lifelong condition that it will affect you for a long time. Dr. Graham Smith calls pregnancy the ultimate cardiac stress test, because it changes everything about your body. And especially if you have what they call hypertensive complications, like preeclampsia, where you have a spike in your blood pressure, protein in your urine, problems with your vision. Those are all problems that are classic symptoms for preeclampsia. But it's not just preeclampsia. If you have a preemie baby, if you have a full-term but low birth weight baby, in other words, you have a full-term pregnancy, but the baby is 5 pounds or under, which is unusual. That tells you that the mother's vascular system, which is what is nourishing the baby through the placenta, there's something wrong with the mother's vascular system. So that's a warning sign. There are a number of pregnancy complications. Gestational diabetes is one, for example. I've got several articles about this on my blog, Heart Sisters, but none of these, when I was in the CCU, which is the intensive care unit for heart patients, every doctor and every nurse on every shift asked me the same questions. Are you a smoker? Do you have a family history of heart disease? Like, everyone was trying to figure out what was it that caused this, right? Because doctors like it if they say, oh, well, she had high cholesterol and high blood pressure and she was a smoker and her mother died of a heart attack at age 30. Then they say, yep, that makes sense. But if it doesn't make sense, then doctors want to know, well, what could be the link here? What was her risk factor? So not one person, though, before I left that hospital asked me, have you ever had any pregnancy complications? And it turns out that could be the most. Dr. Graham Smith said, having a pregnancy complication like some of the ones I've just mentioned can increase your risk of future heart disease 3 to 4 times. Now, that's more than high cholesterol or diabetes as a risk factor. So it's a really important question. So I always ask when I speak to women in my Heart Smart Women audiences, I always say, if you are pregnant or if you know somebody who's pregnant, tell them about this, because it's a risk factor that is often overlooked and still underestimated by a lot of doctors.
This exposes a gap that's actually bothered me for quite a while, a gap in the healthcare system where, you have a baby and maybe you have had some complications, but mysteriously all these things do go away usually when you have your baby. Then you're sent home with your baby and then everything is about the baby, right? And I think it's important. The baby needs to get vaccinated and all of this. And I think you sent me an article about how, when the woman is going back to get her baby vaccinated and that kind of thing, this is an opportune time to have these kinds of conversations. By the way, did you have this? Did you have preeclampsia? I can see that your baby was born underweight or something like that. Have you seen any places in the world where they do this and where it's been successfully implemented, or is this just still a big gap as far as education and even healthcare services that needs to be filled?
I think generally speaking, it isn't yet a standard routine aspect that doctors are looking into in terms of pregnancy. And I think it's fantastic that it's OBGYNs who are leading this charge because they're the ones who see the mums and know what the delivery is like. And the more doctors we have like Dr. Graham Smith, the better it will be, because then he talks at his conferences and he publishes his research and doctors will read the research. But just yesterday, I heard about a new cardiac risk calculator. And these are documents or online services that doctors usually use, and patients can use them too, to find out, am I at risk for heart disease? So a brand new one just came out yesterday. And on Twitter, everybody was saying, oh, I'm going to start using it. The cardiologists that follow me say, I'm going to start using this new cardiac risk calculator. So I looked at the risk calculator. I took the risk calculator myself as I would have the day before my heart attack. So I answered the questions as I would have then. And there wasn't one single question about pregnancy complications. So there's a brand new state-of-the-art cardiac risk calculator that all cardiologists are really excited about now. And so I responded to that announcement by saying, when do you think we're going to have a cardiac risk calculator that includes hypertensive pregnancy complications in women? Because if you don't even ask that question, how can you incorporate it into the risk?
Did you get any responses?
No, not yet. Oh, no, I'm lying, actually. I had a couple cardiologists respond, and that was really, both of them women, turns out, and that both of them said the same thing. I've been wondering the same thing. That's my pet peeve, too. So I know that I'm not alone. Sometimes I feel like I am this sort of cranky voice in the wilderness saying, but what about this? So it's always lovely when cardiologists come on board and say, yes, I've been asking that same question. So we need to ask the question louder, I guess.
Yeah, definitely. I know you're such a good advocate, Carol. I love to see your
I'm loud.
It's good, right? We need it, right? Carolyn, so in regards to women's heart attacks and typical symptoms versus atypical symptoms, and I know there's some really strange symptoms out there that women might not be aware of that are kind of weird, but
I know
they're worth addressing, right?
Yeah, the weird ones are really weird. But I would like to start off by saying that in the wonderful world of cardiology, chest pain is the most common symptom in both men and women. Okay. And the more we talk about these atypical symptoms, and I don't know why we talk about women's symptoms as atypical, because we make up more than half the population. So why would our symptoms be called They're perfectly typical for women. They may not be typical for men, but we don't like the word atypical anymore. But some of these are really atypical. I met women when I was at Mayo Clinic doing my women heart science and leadership training there about 5 months after my heart attack. I met a woman there whose only heart attack was that her lips went numb. Her only symptoms for her heart attack, her lips went numb. And who would go to the doctor because my lips are numb? Another woman said her only symptoms was a persistent cough that just would not go away, no chest pain. And I've heard people talk about symptoms. At Mayo Clinic, they say any symptom between neck and navel that comes on with exertion and goes away with rest should be considered cardiac until proven otherwise. So that's a good way of doing it. So that's why we hear women with, lips isn't even on that list, but anything that like shoulders, upper back, especially arms, left or right arm, elbows. Many women specifically mention that some weird pain in their elbows, of nausea or vomiting. I mean, the list goes on and on. So if you have a number of these symptoms and you present to your doctor and the symptoms don't even makes sense to the average doctor. If you have nausea or vomiting, the doctor's going to go down the path for some gastrointestinal reason for this problem, not to say, this could be a cardiac symptom. So you pretty well have to have chest pain. I say to my audiences, if you do not say chest pain loud and clear, because I know that's what doctors are trained to look for, you can kiss a cardiac diagnosis goodbye. And that is the sad truth. So doctors, I really have high hopes for medical students who haven't learned yet, any of what I'm talking about, because for the last 4 decades, virtually all cardiac research has been done on white middle-aged men, with very low numbers of women, if any women were involved at all. And so the problem is that the research has has extrapolated that if this is true for men, it must be true for women too. Women are just small men, so what works for them should work for women too. But that's so not true, and we're finding that out, in really tragic ways now. That the advice that sometimes works for really well with men, and this goes from diagnostic tools to treatments to outcomes, that we're seeing this real disparity. So I sent you a list of really excellent books that I loved, that I think you're going to share separately. But the theme running through every one of these books, all of them written by cardiologists, female cardiologists, was that women are not small men, and we need to research women. We need to include women in research, which is not happening, even though there's a requirement in the States among funding agencies. So they are the people who fund universities and academic researchers to start their studies. And there's a requirement that you must include adequate, fair balance of male and female. And there's even a further push in the States to include minority groups in those numbers, because up until now, it's been white, middle-aged men. So it turns out that Asian people respond differently, and Black people respond differently. But it's only lately that we're discovering this. And even then, there was a huge, big study in 2019 in the States called Ischemia. And the name of the study was Ischemia. And it was a huge study. Only 23% of the 5,000 people recruited for this study were women. So the study was published in the New England Journal of Medicine. And the headline was, this was the topic of the research: stents and bypass surgery no better than medication for heart attacks. And one cardiologist announced when he saw this study, he said, "Cardiology changes today." So that's how big the results of this study were. But then I had to teach myself how to read I have no medical training. I'm not a healthcare professional, but I had to teach myself how to translate a medical journal article into plain English so I could write about it for my blog readers. And I wrote to the New England Journal of Medicine, and I said, "I fixed the title for you." So now it should be stents and bypass surgery no better than medication in men. And we have to keep adding that and keep reminding researchers, how did this get accepted for publication in probably the most famous medical journal in the world, the New England Journal of Medicine, when they said, well, this is really weird because they're supposed to be showing appropriate balance between men and women, and only 23% of the people studied are women in the study. So it's really hard, even if you see a study, or worse, if you see a press release about a study. Don't believe a study until you actually know that it's been accepted for publication and peer reviewed. That's a quality study compared to some university whose public relations department sends out a press release saying, exciting new research will be presented this week at the big cardiology conference. That's not a proven study. We don't know if it's a high quality study. We don't know if it's 23% women instead of a more 50-50 balance. So that's my little speech about women's lack of representation in research.
Yeah, and I spoke with Dr. Glenn Pyle last year as well, and he does women's cardiovascular research, and it's still a huge issue even to get funding for some of these studies. Right? It's a real challenge for the scientists who commit to researching this, and then there's no funding.
I know, it's crazy. I just heard from a cardiologist back east yesterday who said she's sick and tired of having her grant applications rejected because she is not including men in her study on women's heart disease. Now, for decades, we've been studying men only, and that was okay. But now, today, we're getting women researchers who want to write about women's experience of heart disease, diagnostics, outcomes, treatments, and they're being rejected because they don't include men too. So that's another gap that it needs to be filled.
Mm-hmm. Carolyn, you also mentioned, I think in one of your blogs, this concept of a silent heart attack. Could you explain
Mhm.
that to us?
Yeah, this is a real mystery, especially if you're told that you've had a silent heart attack and you don't even know it. And typically, again, I'm not a doctor, but my understanding is that the symptoms are so different, like maybe that's the elbow problem or something, or the buzzing lips. The symptoms are so odd that women dismiss them. And women are very good at dismissing their symptoms anyway, at the best of times. Even in my case, I dismissed central chest pain, nausea, sweating, and pain down my left arm because a guy with the letters MD after his name told me it's not your heart. So if you dismiss the symptoms, then it's almost impossible for a woman to seriously think, oh, this is probably a heart attack. So they probably thought it was indigestion or that they were coming down with the flu. For whatever reason, whatever happened to their heart at the time was dismissed, overlooked. They went on and they recovered, which the heart is miraculously able to do in a surprisingly large number of patients. And then it's usually later on during a subsequent test, maybe an unrelated test, where the doctor will say to the patient, oh, it seems that you have had a cardiac event based on these new studies, new tests that we've just run. Now, many people think, well, I'm glad that's over with. That's weird, but I'm glad it's over with. But it turns out that the research that's been done on silent heart attacks suggests that there's a high rate of death within 10 years following a silent heart attack. And that's the same figure as if you'd had any other type of heart attack. Now, that's frightening because you could be dismissing the symptoms of a silent heart attack and then turns out to be just as dangerous for you. So that's why I really urge women, if you have you know your body, and if you have a bunch of things happening to your body that just don't feel right, then pay attention to those symptoms.
I remember last time we spoke, Carolyn, you mentioned about how women need to talk to their doctors.
Yes.
This is such a
Yeah.
concern for me because even right now, I think that women, everyone sees that the healthcare systems are overwhelmed. Accessing healthcare, accessing a family doctor, many people cannot even access their family doctor. The thought of going to emerge with an hour-long wait, and women are first to dismiss these symptoms and say, oh, it's probably nothing. I'm
Yes.
probably okay. And everything else is more important. I remember last time you spoke, you even gave me a list for the things that are more important. And I think even the family dog got more higher priority than her, right?
Right.
So Carolyn, can you speak to this issue and speak to how can we talk to our doctors? Because I remember the other thing you said was that we often like to tell stories as women, and that does not compute very well when you're talking to a doctor that is trying to make a differential diagnosis,
Yes.
right?
Yes. I like to quote a researcher. She's a Canadian, but she's at Harvard now, and she studies how women speak to doctors in the emergency department, which is my favorite subject in the world. It's a very niche kind of small area she studies, but it tells a lot. So she hangs out in emergency departments for a living, and she just reports what's going on between the women and their doctors. And she has found that women do all of those minimizing things, and then they finally get to emerge. And she said, I have seen with my own eyes a woman arguing with the doctor when he says, well, tell me about this chest pain. And then she'll start saying things like, well, it's not really pain. It's more just like a pressure or something. And then she'll start self-diagnosing. Well, it's probably, I was out gardening yesterday. Maybe I lifted something heavy. It's probably just a pulled muscle. So I urge women to shut up. Just go in and say, if you're having chest pain, pain is often described by women as pressure, fullness, heaviness, ache, rarely chest pain. And part of the problem is if your listeners Google heart attack signs and images, so you're looking for pictures of people having a heart attack, I guarantee you will see dozens and countless, hundreds, millions of photographs of old men clutching their chests in agony. And that to us is a heart attack. Well, that is a man who's been told by the photographer, act like you're having a heart attack.
Yes.
Because the reality is that's probably what they're imitating, what they're pretending to have is probably sudden cardiac arrest, which is that agonizing central chest pain, collapse to the floor, 911, CPR, ambulance. I mean, that's an electrical problem of the heart, often caused by the blocked artery, which is the plumbing part that really is a heart attack. So heart attacks are plumbing problems where there's a blocked pipe, and sudden cardiac arrest is an electrical problem that's caused when the electrical system of the heart is damaged because there's a blocked pipe. So if I was a woman and my only image of heart attacks is this old guy clutching his chest and then falling down unconscious, when I have my symptoms, which are, stomach related or upper back or elbow buzz or buzzing lips or whatever, I'm not going to think, I'm going to think, well, but I don't look like that guy. How could I be having a heart attack? Like when I had my heart attack, I was sent home from a merge. I immediately went back to work. So really, he must have been right, because how could I go to work and drive my car? I flew to Ottawa for my mother's 80th birthday. I could do everything a normal person could do. So that proved that he was right in misdiagnosing me. Well, he wasn't right. It's just that the way women experience cardiac symptoms can be very different. I mean, women have sudden cardiac arrest symptoms as well, but it's far more common that we will have what they call slow onset symptoms. So these are not the kind of symptoms like we picture and in the media are portrayed, where you have a sudden, horrible, agonizing event, boom, you're down on the ground unconscious, and you probably die right down there. So it can be very different when we're looking at sudden or slow onset versus sudden onset.
Mm-hmm. And it makes me think of, I know we had a viewer, again, with our last interview, and she had watched the interview. She went to take her dog out for a walk after the interview, and she started to feel like this pressure, kind of weak, and she was about to dismiss it. And then she thought, oh, wait a minute, I just watched that interview. I better get checked out. And as it turns out, it was angina, right? And so,
wow.
Yeah, so it's really important to think about even that exertional pain that goes away with rest, right? Like that's one way to
Yes, that's the key. It'll come on with exertion and go away with rest. That's your typical definition of angina, or angina, as they say in the States.
Mm-hmm. And you had mentioned earlier cough being a symptom. Now, that's a really tricky one because there could be many different reasons why you have a chronic cough. Right now, there's a lot of respiratory infections going on. Some people have chronic cough from COVID-19. Also, ACE inhibitors, which are a medication that's used for blood pressure, can cause chronic cough. And so talking to a healthcare professional can really help to figure out why this is happening, right? So if you have a chronic cough, don't just put up with it, right? There's a reason why you have this, and you need to be assessed adequately.
Yeah, for sure. It's a fine line, isn't it, between being conscious of your body and what doesn't feel right and deciding I'm going to seek medical help, and the other half of, or the other 3/4 of ourselves that say it's probably nothing, you're too busy, maybe tomorrow if it's still bothering you. And then self-diagnosing, which is what we tend to do. I wanted to mention an article or a research study that I read years ago out of Oregon, and it talked about the 6 behavior patterns that women use. It's called treatment seeking delay behavior. Mm-hmm. And one of the main features of being of asking for help is that you have to identify the symptom as being possibly cardiac. So that requires that level. But there's 6 levels here that I thought were funny. And there's only, not funny, haha, but strange, because they're so common. And when I talk to women in my audiences, they all smile and nod and say, oh my God, that's me. So see if these sound familiar. The first one is the only good one, and that's knowing and going. Women know something is wrong and they decide to go for help. And that's the gold standard. That's what we all should be doing. The second one is the behavior pattern is knowing and letting someone else take over. So that's where you start feeling sick and you mention this to somebody, your friend, your daughter, whoever you happen to be with. Gee, I'm having this. And they say, oh my God, that could be a heart attack. We're taking you to the ER, or we're calling 911. Then there's knowing and going on the patient's own terms. So this is the person who says to her friend, oh, I'm having something weird happening. And she says, oh, well, you should go to call 911. And she says, nope, I know it's nothing. It's probably what I ate for dinner last night. So these are also the people who drive themselves to emergency. I had a person in my audience once at one of my talks who took the bus to emergency during her heart attack. Wow. So these are people who won't listen to what other people think they should do. They need to do this on their own. Knowing and waiting. This is so common. This is where, yes, I know I'm feeling really terrible, but maybe tomorrow, if it's still bad, I'll call my doctor.
I think I would do this.
Yeah. I'll see how it works overnight if I'm still alive tomorrow. I had a woman in my audience whose first symptom happened on the morning of Christmas Eve, and she was really sick. She was like me. She was having classic textbook heart attack symptoms. And her son, she must have looked like death warmed over, because her son said, Mom, we're calling 911. You look horrible. And she said, honey, I have 12 people coming for Christmas dinner tomorrow. How can I go to the hospital? So for her, it was a very simple decision. Maybe after Christmas, if I get around.
It's funny, but it's, you know what, it's true. It's
true. I know. And the other one is, there's 2 more left. One is managing an alternative hypothesis. This is how researchers talk. But this is where women say, they don't even think about heart. They think, oh, well, it could be, that spicy food I had last night, or working in the garden and I pulled a muscle, or, maybe I should get my gallbladder checked, or I've been under so much stress lately that's probably what the problem is. So they have these talks with themselves. And the last one, and what I did nonstop during my whole experience, was minimize. It's not that bad. If it gets really bad, then I'll call the doctor.
Yeah. And because you were misdiagnosed, it was much more difficult for you because you were fighting this diagnosis that you had been given. I remember.
Absolutely. And I believe that, because he's a doctor. He told me very confidently. Oh, and there's the other story that I think I told you last time. Before I left the hospital, after being misdiagnosed and told I had acid reflux, the nurse from emergency came up to my stretcher, and she said to me very sternly, scolded me, said, you'll have to stop asking questions of the doctor. He is a very good doctor, and he does not like to be questioned. Well, it was like my face had been slapped. I could not get out of there fast enough. So there you have not only the doctor telling me that I don't know the difference between indigestion and a heart attack, and now his colleague is also scolding me for making trouble with the doctor. So no wonder I didn't go back. When my symptoms came back, which they did, of course, there was no way I was going back to that emergency department.
Mm-hmm. And you actually worked there. So
I worked in the hospital, yes.
It wasn't even an unfamiliar place for you.
No.
And I remember you saying when you were suffering during that 2 weeks and you were having this terrible pain, you kept thinking, man, this acid reflux, I don't know how people live with this.
I know. I know. I wasn't doubting at all that I knew I had acid reflux, so I was popping Tums and Gaviscon like crazy. But I was surprised. This is so bad. Like, and I'd ask my girlfriends, have you ever had acid reflux? Is it this bad? Because this is pretty bad.
Carolyn, I wanted to talk about after you had your cardiac event and you were sent home to recover. Could you tell us a little bit about how did that affect you mentally, and what do we know about the mental health implications of going through something like this? Did you have enough support? What should people know if they're listening to this and maybe they have a family member or they themselves have just been through something like this?
Yeah, that's such a good question. I'm so glad you are mentioning that because this is really an underappreciated aspect of having, I would say any catastrophic medical diagnosis. This is not unique to cardiology. So, cancer patients have exactly the same response. Anything that you see that comes out of the blue that you're not expecting, that you didn't see yourself as, is not even on your radar at any time. And we know that about up to 40% of freshly diagnosed heart patients, as I call them, have what's called new onset depression or anxiety. So these are people who are not prone to depression. And by the way, that's a risk factor in itself for developing heart disease. Depressed people are far more likely to develop heart disease than people who don't have a history of depression. But if you've never had any experience of depression or anxiety or any mental health issue at all, you can still get plunged into this very surprising depression or anxiety or just a terrible mental state, this post diagnostic depression. And there's a cardiac psychologist in Alaska who follows my blog, and he counsels heart patients himself, and now he is a heart patient himself. He's had a number of heart attacks. And he says having a heart attack is a very anxiety producing event. Like if somebody says, "I don't think it's your heart, I think you're just anxious," I would say, yes, she is anxious, because there are few things in life more anxiety producing than having a freaking heart attack. That'll throw anybody off the deep end. Even the most calm, serene, Buddhist yoga practitioner would be very anxious about the fact that there's something wrong with your heart. There's something metaphoric about the heart and what it means, not just as an organ. It's not like I worry about my kidneys or my liver, but the heart has an entirely different spiritual and emotional and psychological meaning for us. So when someone tells you like the very unfortunately named diagnosis heart failure, when a doctor says you have heart failure, your heart is failing, that as one cardiologist said, who also wants to change the name as I do, she said, it's funny that we're still using the word heart failure in cardiology, because if you go to see your foot doctor, you don't say, "I'm going to the foot failure doctor," but we still say that in cardiology. So getting back to the depression, though, they estimate about 40%, as high as 40% of newly diagnosed patients will suffer this, and almost none of them have been warned. Nobody before I left the CCU said, "Oh, by the way, here's this symptom. It's very common. You might have it. It's temporary. It's treatable. It's usually benign. It doesn't mean you're going to be depressed for the rest of your life, but it's called situational depression." So psychologists call this the body's reaction to something that they are so shocked about and so surprised at that it takes them a while to get their head wrapped around what's happening to them. So situational depression is not like having, lifelong, serious mental illness, but it's very serious if you're the one who's having it. And I experienced this shortly after my own heart attack as well. And swirling around in all of these emotions was the sense that I should be happy. Why am I crying every day? Why can't I get out of bed in the morning? Because I should be happy because I survived this and it was successful and they fixed me and I'm fine now, but I wasn't fine at all. And then I felt guilty for not being grateful for all the help I was getting and for my friends' help and my wonderful family who all, flew out from across Canada to be with me and to help me. And instead of being grateful, I was kind of moping around the house and I just couldn't seem to pull my socks up and get on with it. And then that was very stressful. Like, what is wrong with me? What is happening to me? Why can't I just, do what I used to be able to do? So for a person who had never had mental health issues or depression or anxiety, it was especially confusing and puzzling, and also something I couldn't talk about. I couldn't mention it to my family at all because they had already suffered so much just worrying about what I was going through with my heart attack and recovery. And as I said, they flew back home to help me. So I couldn't worry them. I didn't want to put my children, I never want to see that look on my children's faces ever again. So I felt like I can't mention it. I just pasted on my smiley face. And, whenever I had to go out to the grocery store, to the bank, or to the pharmacist, I would paste on my happy face and try to not to upset people.
So if you knew someone who had just been through a cardiac event and you know that they're at risk for this, what would you tell them in terms of how to cope with this? What supports are out there? What would you tell the Carolyn that went through this years ago?
Well, I think that the Carolyn that went through this years ago wouldn't have believed that it would be possible for a person like me to ever have this. So right away, I was in, extreme denial. But those three terms: it's common, it's temporary, and it's benign. So this doesn't mean you're going to be like this forever. It will get better. And it's so common. And just knowing that it's common, that I don't have to panic about the way I'm feeling, because I'd never read anything about heart patients who can't get out of bed in the morning because they're crying so much. But if somebody tells me, oh, by the way, this is something to be expected, it's a normal reaction to when something bad happens to you, that you will have some kind of emotional and psychological reaction to something really catastrophic. And for most people, a life-changing diagnosis is catastrophic. And then you will get used to it. There's a lot of interesting research on the sense of self. And when you are diagnosed with a chronic progressive illness, which heart disease is, by the way, that the loss of self is something that has been compared to grief, because you're not the same person that you were the day before this happened to you. And you haven't yet replaced that self, that person that you used to be, that you knew and could manage and knew how to do things. You haven't replaced that person yet with equally valuable or acceptable or positive replacements. And that will happen eventually, but it doesn't happen in those first swirling weeks or months where, you're just trying to make sense of it. But getting back to your question about what can you do about it, that's a depressing situation right there, because it's difficult to seek mental help. Mental health professionals will tell you that they're booked up solid. If you go to see a psychiatrist, it's covered under our medical plan. But if you go to a psychologist, you have to pay whatever the hourly rate is. So that in itself can be a huge stressor for some families, especially when you're suffering financially. My American counterparts, for example, who've had to pay tens, sometimes hundreds of thousands of dollars for their heart attack stay in the hospital and ongoing cardiac visits, seeking psychological treatment is out of the question. They just can't afford it. So, but there are lots of online resources. I'm really happy to see this. It's kind of a blessing of COVID, I think, too, that there are a lot of really good websites about mental health. The Canadian Mental Health Association has a really good website with some links to resources. But, most of the beauty of that is just hearing that you're not alone. You're not the only one, that this is happening to lots and lots of other people. And I remember when I was still in the CCU and this woman came to my bedside. She was a hospital visitor and she had been a or a heart attack survivor like me. And she was walking and talking and looking pretty nice. And she was telling me about her heart attack experience and inviting me to a series of lectures for new heart patients that we have here in Victoria. And I said, sign me up because I want to be like you. I don't want to be where I am now. I want to be whatever it is you've done to get to that stage. That's very hopeful because lying in the hospital by yourself, thinking, what the heck has just happened to me? You really have no idea how to put one foot in front of the other and what's going to happen next.
And I think just listening to you, Carolyn, will be so encouraging for people to see, that life does go on after an event like this, and it takes time. You have to be patient with yourself, right? But that things will get back to normal. It might be you might feel like you said like a bit of a different person, right? Because of what you've been through and the reality of that, right? But just listening to what you're saying there, it also made me think about friends and family. There was just a report out on loneliness and what a big problem loneliness actually is, and it's just starting to be recognized, and it is a risk factor for other health issues. And friends and family do circulate and they want to come and support people who have been through something like this. What are the most helpful things that people could do, and what are the most maybe non-helpful things? What do people need at this time?
You mean from their friends and family after they've had a cardiac event? I'll tell you one thing that I found very helpful, as opposed to what I usually heard, which was, let me know if there's anything I can do. Well, at that stage, I was so overwhelmed. I don't know what you can do. And I don't want you to say, would you come over and clean out the kitty litter box? Or something. Like, I just can't ask people that. But when people would phone from the grocery store and they would say, I'm at the grocery store, what can I pick up for you while I'm here? Well, I'd say, well, as a matter of fact, I'm running low on this, this, and this. And the next thing you know, she's at my doorstep and delivering my whatever my groceries are, and we're having a little chat. So that question, I'm here, what can I pick up for you? Or I have a free day on Thursday. I thought I'd bring lunch for you. What would you like? Fish or chicken? So those kinds of things where it's not like you tell me what you want. Like here's an example of somebody I barely knew. I worked with this woman at hospice. She was our gardener. We had where I worked at the hospital, there's a beautiful rooftop garden, and our professional gardener who took care of the garden every week knew me for years and years because we saw each other at work. And after my heart attack, she showed up at my door because it was springtime. I had my heart attack in May, and she knew that this is the month I usually would be putting out all my annuals in the garden, but she thought I might need some help. So she shows up with flats of all these beautiful spring flowers, and she planted my annuals for me. And then we had tea, and then she said goodbye. And so she wasn't a close friend, she wasn't a neighbor, but she was a colleague who knew, because she's a gardener and she thinks like gardeners do, who are wonderful. And she did my gardening. So that's a gesture that I was so happy about. And I remember I sat here in my living room and I could look out the window and I was watching her working away and humming. And I thought, oh, this is just so lovely. And, there's the classic things like, bring muffins and casseroles and all those things. I like to recommend that you bring a big bag of salad because number one, salads are healthy for you. And as you know, I have this aversion to vegetables. So I liked having a Ziploc bag of ready-made chopped up vegetables that I could just pour onto my dinner plate. And that would be my lunch. So if you're creative in terms of doing something or saying something or just picking up the phone and calling people and say, I'm just thinking about you.
Yeah, I think that can go a long ways. And I would probably say shorter visits are better.
Oh, yes. Yes. When my son was here, when he was taking his shift, taking care of me, he wouldn't even take people's coats at the door. When my visitors came.
A good strategy.
Yeah, he would stand beside them, like near the door, and say, Mom's pretty tired today. And then sort of usher them out of the apartment. pretty quickly. So you don't want them to get settled in. I had one visitor who I had not seen in 15 years. She was a former acquaintance, and she heard I had a heart attack and she was stunned. So she phoned me and she said, I'm coming right over. So she comes over, sits on my couch, and she stayed for 2 hours. And I was sitting on the chair. I was so tired. I just wanted to say, go home, please go home, please go home. I could hardly keep my eyes open and I collapsed. I don't know where my kids were at that time. They must have left the building. But that was an example of don't rush to somebody's door if it's outside the limits of your current relationship. So if you're a close friend, yes, you can phone them, drop over, bring your muffins or your salad or whatever you think is going to be most helpful. But if you don't really know this person, then don't impose on them and stay for 2 hours to a person who really should be napping instead.
Mm-hmm. And Carolyn, you mentioned your editorial that was just published in the British Medical Journal, Heart Failure, It's Time to Change the F Word. So I thought
Yes.
this is such a spicy title. Um, Tell us about the F word and why we need to change this. I agree. It is.
It's very
Once
hurtful.
I saw
Yeah.
your editorial, I thought, you know what, that's true.
No,
Why do we use
I
this
know.
terminology?
Well, this is a movement that's growing among cardiologists actually to change the name. And we're not alone. There are many diseases in medicine that whose names have changed. For example, AIDS, HIV AIDS used to be called GRID, GRID, short for gay-related immune deficiency, until the 1980s. And somehow the medical profession got used to a new name. So, you know, stroke used to be called apoplexy. If you were intellectually challenged, you used to be called mentally retarded. So we've changed a lot of names of conditions, and yet doctors who treat heart failure patients are reluctant to change the name. One American cardiologist said, we can't change the name because it's in our billing codes. So, like
Oh, I
we
see.
can't do it different because we've always done it this way. But a number of cardiologists are on board who really say it's a very hurtful thing. And I first got involved in this whole debate. I don't have heart failure. I have two other heart conditions, but not heart failure, touch wood. But I had a reader, one of my blog readers wrote me this paragraph that just broke my heart. She said, I couldn't hear any more words once the doctor told me you have heart failure. She said, failure? My heart is failing. How could I live if my heart is failing? And then she said, I left the office. I went down to the parking lot, but I couldn't get into my car to drive myself home. How could I drive my car if my heart was failing? I felt like death was imminent. That's approximately the gist of what she said. So imagine telling you that an organ as important as your heart is failing, and it's not even an accurate name. It doesn't mean that your heart is failing. And many cardiologists have told me, well, when I tell somebody that they have heart failure, one doctor said, I use air quotes to say
Oh.
failure to show that I don't really mean failure. And my response is, if it doesn't mean it, then stop saying it and come up with something different. And a number of cardiologists have come up with some lots of alternatives that are far less hurtful than telling somebody that their heart is failing. And the other thing about the danger of being told that you have such a horrible negative diagnosis is that many patients just throw their hands up and, like this woman said, how could I live? Why would I leave the building? Why would I do anything? Or I can't leave the building. So this means they're highly unlikely to do what the doctor is telling them to do, which is to take your medication and get your exercise and quit smoking and eat a healthy diet and do all of these healthy things that will help your progress if you're diagnosed with this condition. But because you're still reeling over the words of the doctor, you're highly unlikely to do the very things that you should be to help you feel better.
Yeah, it does have a very hopeless connotation to it, this
Really.
this term. And
Yeah.
if you're having to use air quotes during your diagnostic conversation, I think that's a probably a red flag.
It is, yeah. Yeah, that's a sign. There was
Mm.
a really interesting study out of Italy where three groups of stakeholders were asked their opinions about dealing with heart failure. There were patients, there were family caregivers, and then there were the cardiologists who cared for these people. And when they were surveyed, they had to describe their initial reaction to this, to hearing the word heart failure. And the patients and the family members used words like fear and anguish.
Mm.
The doctors use the word optimistic. So
Wow.
it's like they're on different planets. They are on different planets, that they are not putting themselves into the. If you think that you could tell somebody that a major organ is failing and wave them goodbye, um, and not know what kind of an effect that would have. So it's like, um, as I had a patient actually say, well, when my doctor told me I had heart failure, it made me try harder to survive. And I thought, ooh, good for you, because that's not what I'm hearing from so many other people who it stops them right in their tracks and they give up hope. It's hard to be hopeful when you have an organ that's failing, as opposed to um, many people live for many productive years with heart failure and their doctors help. So that's what you want to stress. You want to stress, here are some ways that we can help you feel better, live longer, and as opposed to saying, oh, too bad, you have heart failure.
Yeah, this is why I love having people like you on the channel, Carolyn, because it's great to have experts who are, physicians, scientists, researchers. But, we really need to talk, I think, more to patients and people that have been through this because their experience is equally as important, if not more important. If people feel like their diagnosis is hopeless, they're less likely to take care of themselves, to like you said, take their medications, to do things that will help them to live a better quality of life. And so sharing stories like yours, Carolyn, you've just done such an incredible job with your blog and your book. And, I think it's just so important. Everyone loves to have a fancy doctor for an interview. But I think these interviews are even more important because you're on the other side of things and these are real people's stories, right? You've actually been through this yourself.
Yes. Well, and not only that, but I really feel lucky now when I write my blog articles. I know that there are other women, not just here locally, but all around the world in 190 countries who are reading these and they're feeling less alone. My favorite comment years and years ago was a woman who wrote in after reading one of my blog articles about some common thing that you can expect to happen. And she said, oh my God, are you me? Because whatever I can't even remember what it was, but whatever I was writing about heart disease or some symptom or something, she was having exactly that same thing and really worried about it. So, like most things in life, knowledge is power. If you know, even if you know something bad, like I always think getting a bad diagnosis is better than no diagnosis. The worst thing is not knowing or worrying about it's going to be worse than it is. And lots of us are professional worriers. So, especially around our health and especially around the healthcare system that we're watching now, it's really frightening. Like to think that, if my granddaughter needed help, emergency help, she might be waiting 8 to 10 hours in emergency. So I think a lot of us are frightened about a lot of things these days. But any little bit of reassurance or information that the way you are now, we can be fixed. And I don't mean fixed permanently, so you'll never have heart disease. Doctors tell us that heart disease is a chronic and progressive disease, but in my case, this is 17 years now that I'm heading into my 17th year, and I never would have expected that I would still be alive today. As a matter of fact, I think I may have told you last time that when I first got back from the hospital, I had this terrible feeling, except it wasn't like a depressing, awful thought. I just knew that I was going to die in my sleep, probably tonight. So that before bedtime, I would tidy everything up, empty the garbage, and take out the recycling and make sure all the counters were clean so that the next day, when they found my corpse, the house wouldn't be a mess. Like that's really an odd response, given that I wasn't upset. It's not like I was crying, thinking I'm so scared I might die. I just knew I was going to die because of the damage to my heart, and I knew what had happened to me. And that's what happens to people who have heart attacks, right? They die. So to have that kind of response, and then here I am 17 years later, and I thought, haven't died yet. And for a while there, my apartment was, in pretty spiffy shape every night. So I think I got tired of doing housework every night before bedtime. That's why I finally said, you know what, I'm going to bed.
And I'm glad that you poured that energy into your blog. You have a book called a Women's Guide to Living with Heart Disease that was published by Johns Hopkins University Press. I
Yes.
know you had a couple other books you wanted to share with us.
Well, the three books that I told you about, I usually warn people, though, it basically they are the history, except for one, which is really interesting about how the heart works, which is really good. But they're all so good. But I warn people to take your blood pressure medication before you open these books, because you'll just be shocked by the history of women's health in general.
Mm-hmm. And we'll link your blog in the description as well, because that's just such a refreshing place for people to go and read information that's you've digested it very well. Like you said, you learned how to read studies and how to communicate them, right? And you do such an incredible job of that. And 190 countries around the world, right? People are reading this blog of yours. Carolyn, is there anything that we missed? I mean, I wanted to ask you what your message would be to women out there who are listening to this and who know that you've been through this and you've come out the other side of it and you've actually done, incredible, right? But what would you say to women who might be listening to this today and just what would your message be?
Yeah, that's such a good question. My favorite advice on that line would be to say to women, you know your body. You know when something is just not right. And then take action, make decisions that are the same decisions you would make if this were happening to your mom or your daughter or your sister or any other woman you cared about. So, for example, when I was on that flight from Ottawa, 5-hour flight, Ottawa to Vancouver, I had 2 cardiac events on that flight. At no point did I flag the flight attendants because I didn't want to make a fuss. And I certainly didn't want to be one of those passengers they have to turn the flight around for because of a medical emergency, which I knew was just indigestion. Whereas if that had happened to my daughter, if my daughter Larissa had been the one with those symptoms on that flight, I would have been screaming. I would have been demanding that they turn that plane around. So I would do that for her, but I wouldn't do that for myself. I just tried not to make a fuss. So women, I think you refuse to make a fuss at your peril. Many of us are afraid to be seen as difficult, especially in the medical profession. We don't want to be seen as the difficult patient, but that's the only way to get attention. So I'd rather be difficult than dead. And there are, many, many wonderful doctors out there. I've met so many lovely cardiologists, and I'm so happy that there's a whole movement called Women in Cardiology. It's based in the States, and these women are amazing. They're just powerhouses, and it's like they're not taking it anymore. They're not taking any of this anymore. So I have high hopes for the medical students that we're reaching, actually.
Yeah, and I think we probably will see change with advocates like you and like movements like this, women in cardiology. And it's so backwards, isn't it, Carol? When we think about how as women, we think we don't want to cause a fuss, because there's people depending on us, and it's that whole concept of putting on your own oxygen mask first. Is what I thought of when you're saying that, because
Yes,
take care of yourself first, because there are so many people depending on you.
exactly.
Like preserve yourself and then
Yes.
help others, right?
Not sacrifice yourself so nobody will be inconvenienced. That we've got to let that go. And yet it's a societal shift. Really, it's not just an individual one by one shift. It's a societal shift about how we raise girls. I mean, I certainly was raised in a way that, children should be seen and not heard, and don't make a fuss and don't make noise and be polite. And go along to get along. Whereas sometimes if you do that, like I did, when I was told I had a heart attack or I wasn't having a heart attack, I just went along with it.
Mhm.
And when I said, my one question that I did ask the doctor was, but what about this pain down my arm? And that's when the nurse came and yelled at me for that. So that seems to be, that's a societal way that people think it's okay to treat women.
Mhm. Carolyn, thank you so much for sharing your story once again, for taking the time to be here with us. It's always so refreshing to speak with you, and it's so encouraging. If you're a woman or a man and you're listening to this, please do share this with at least a couple of other people. You could literally be saving a life. We know one woman whose life might have been saved from just listening to Carolyn's story last time. And thank you for all the work that you're doing. We'll have the links to Carolyn's blog and her book, and even some of the articles that we mentioned here, and Carolyn's favorite books as well. So you can look in the description for those. But Carolyn, thank you so much for being here. It's always such a joy to talk with you.
You're welcome. Thank you so much, Lindsay. You're a fantastic interviewer. You are.
I don't know about that, but we do our best.
Yeah, you are.
Okay, well, take care, Carolyn.
Hey, you too. Bye-bye.
Bye.